some diagnosable mental health disorder over the course of their lifetime. And then, you know, you see that with sex, it's really not that different between males and females. And as you get older and older, obviously your risks increase. As far as what kind of issues present in childhood, you know, if you're looking at a group of kids just in a 1 year period, you'll see that about 13% of them at any given time could have a diagnosable mental health disorder. Now, common things being common, you'll see that ADHD makes up the majority of that. And this is looking at 8 to 15-year-olds. So when you're talking about especially kids before puberty, major mental illness, you know, psychosis, bipolar disorder, extremely uncommon before puberty. Depression even is relatively uncommon before puberty. But you know, depression is about 3% in that age range. Anxiety is about 1% in that age range. Okay. And then we'll talk a little bit about depression and anxiety, what they look like. When you know, we're using these terms diagnostically, we've got something called the DSM, the Diagnostic Statistical Manual, and it lists a bunch of criteria for any kind of mental health concern. So, you know, you kind of, you're talking to a family, talking to a patient, seeing what they're describing to you, and you know, if they're describing that those symptoms are present over an extended duration of time and is causing significant impairments in the child's functioning, yeah, that's when we use a label of a disorder. And under the broad umbrellas of anxiety and depression, you've got a lot of kind of subcategories of disorder. So commonly in children, we'd see separation anxiety disorder. You know, this is going to be a child who is having trouble being away from the family. So, you know, they're with those people that they're closest to, functioning just fine. No trouble at all, happy, interacting, engaging. But when they're away, you know, that's when the anxiety really manifests itself. So a lot of kids, as they're transitioning from, you know, in that early grade school period, you know, really, you know, first beginning here, you could see separation anxiety manifest itself. Now, you know, with these kind of disorders, you know, you do have to kind of keep in mind the developmental level of a child. So, you know, if you're thinking about, you know, those toddlers, you know, kind of, you know, 18 months or so, of course you're going to see stranger danger, and all kids kind of have that naturally. You know, they want to be just with mom. But as you get older and older, your comfort level should expand some. So, you know, if a kid is, you know, consistently unable to sleep in their bedroom, you know, they become tearful, anxious when they're getting dropped off at school, but the problems resolve immediately when they come home, you know, that would make you suspicious of a separation anxiety disorder. And a lot of these kids would also present with a lot of what we call, you know, somatic physical complaints and symptoms, you know, headaches, stomach aches, I'm feeling sick, so I can't go to school. And, you know, naturally a parent's going to want to, you know, protect their child if they're having complaints like that. And so then you can kind of get into these patterns where you're missing more and more school days, and it sort of reinforces the anxiety that, you know, if I start feeling this way, I kind of get what I want and I get to come home. With generalized anxiety disorder, that's just kind of too much worry about every little thing in the world. So, you know, kids are going to be worried about their family's safety. Kids are going to be worried about their own safety. They're going to be worried about their academic performance. They're going to be worried about, you know, international global conflicts. And, you know, we all carry some of that around, right? I mean, you know, we've got all this going on in the world. You know, you have to pay attention to it. But again, you know, with when we're talking about making a diagnosis, we're talking about when it reaches the stage where it's becoming a problem instead of a help. Because a little bit of anxiety, it motivates you. You know, a little bit of anxiety about school gets you to study. Too much anxiety, then you know, you can't concentrate. You know, you're nauseous, you're tense, you're irritable, and you know, it starts to degrade your functioning. Social phobia or social anxiety disorder. That's when kids are doing well in most settings, but they just begin to freeze up when they're going into those larger environments, larger interactions. And again, I think pretty much everyone experiences a little bit of anxiety. There's no one who enjoys public speaking that I know of, but you get through it. You have your water to help with the dry mouth, and things roll on. But when the anxiety stops the kid from getting out there, doing what they want to do, they're not able to talk in class, interact in the environment there. They're withdrawing from activities that they previously enjoyed, sports, church, youth group, that sort of thing. When they're cutting those things off because of the anxiety and the fear that they're going to make a mistake in public, that's when we look at it as anxiety disorder. Panic, when we're talking about panic, we're talking about kind of that overwhelming sense of fear and dread, right? So, your body just kind of goes into lockdown. You're shaking, your heart's racing, you start hyperventilating, you get that tunnel vision, feel like you're gonna pass out. And panic, if any anxiety issue gets bad enough, you can have panic attacks and a panic disorder. So oftentimes you might see it, in these other presentations, but sometimes you can just have panic by itself. There can be triggers. Again, you might be prone to panic attacks when you're doing public speaking, or you might have a specific phobia. You're afraid of dogs, and that triggers a panic attack. But sometimes it'll take on a life of its own. Just kind of the worry, the concern about having a panic attack can start bringing it on for some kids. Just because I guess we don't have enough to do with our time, about every 5 or 10 years, we'll rejigger the DSM, the Diagnostic Statistical Manual. And so post-traumatic stress disorder, obsessive compulsive disorder used to be conceptualized as anxiety disorders. And a lot of clinicians still see a lot of overlap there, but they kind of have been moved into their own respective territories, with post-traumatic stress really being considered more of a trauma issue now, which makes sense because, as you all know, sort of the beginning of that would be you've had some experience where you felt like your life was in danger. And then obsessive compulsive disorder, that's going to be intrusive thoughts, obsessive thoughts, and ritualistic behavior. Which, again, when you're talking about like medication management, that sort of thing, you're going to take the same approach as you would with any other anxiety disorder. But neurobiology behind it is definitely different than traditional anxiety disorders. So, again, some anxiety, normal to the human condition. We all deal with it. It can be a warning sign to us that we need to get out of there, that something's not quite right. But it can snowball. It can become a problem or issue for some people. So when you're thinking about your students, again, if you're having multiple missed days because you can't be away from your family, if you're about to talk in class and you start getting the physical symptoms of panic, shaking, can't breathe, hyperventilating, numbness, tingling in your hands and lips, that's an issue. Or if just kind of this overall burden, the weight of anxiety is becoming too much, and it starts impairing with sleep, with social obligations, causing increase in irritability, leading to conflict. These are signs that, again, it might be getting to the point where it's moved from being something protective to something problematic. So, I mentioned earlier that many childhood or many psychiatric disorders we don't really see too much in childhood, but anxiety is one that is very present. And again, beginning of school, with the students who are first entering Augusta prep here, you'd want to be on the lookout that they're not experiencing a significant amount of anxiety as they make kind of this life transition and are spending more time out of the home. And then after puberty hits, that's when we usually see the onset of most mental health issues. So, with the teenagers, again, you want to be on the lookout that they're not beginning to develop issues with anxiety. It's relatively uncommon that you'd see like separation anxiety and related to that selective mutism. That's just when you can talk, but you're not going to talk because it's sort of, you're worried about these social interactions, so you just kind of say, I'm out of it, I'm not going to participate. But you get the kid at home and they're talking up a storm. With those issues, usually you're seeing those really in a younger population. I have worked with teenagers that had experiences with both, but the majority of those are going to be early grade school kids. Yeah, so when we're talking about treatment of mental health issues, and this will be a little bit redundant when we get to depression as well, but you're really thinking about kind of a three-pronged approach. The first being lifestyle. What can we do just to help, without medication, without talk therapy? What can we do to kind of facilitate a healthy lifestyle for a kid that's going to minimize anxiety? So obviously, if there's specific stressors that are triggering the anxiety, and a little bit later we're going to talk about bullying and things like that. So if we can put our finger on something that might be triggering the anxiety for the child, of course we're going to take steps to try to help them correct it. All the adults in the room, I'm going to wager, have a larger skill set to offer as far as coping strategies than the younger kids that are around us. So a lot of times we can really help kids problem solve and work through these issues. Diet, you will find some people where anxiety gets a little bit worse if they're getting hungry, their blood sugar begins to drop, and they note some of those physiological changes that come along with that, and they can get a little jittery and feel a little bit distressed, and then that can kind of snowball the anxiety problem. So, it's not every kid, but sometimes you do want to make sure that they're not, skipping breakfast, and then they've got a late lunch, and so, their body is just kind of feeling off. Exercise generally is protective. It's a good thing. You're increasing, blood flow to the brain. Exercise is good for concentration in class. Exercise is good for reducing anxiety. Exercise is good for improving mood. So just encouraging kids to stay physically active is always helpful. You want to watch caffeine intake. Obviously, that's going to potentially precipitate anxiety for some people. Hopefully it's not an issue with grade school kids, but high school kids do start getting into coffee and energy drinks, and it can cause problems. And then sleep is a huge factor for mental health as well. So ADHD, worse if you're not getting sleep. Anxiety, worse if you're not getting sleep. Depression, worse if you're not getting sleep. And when we start to think about kind of talking about suicide and why are rates going up now, sleep could actually be a big factor there, because each year that goes by, it becomes easier and easier not to sleep. I'm sure most of you are similar to me. There was a time where there wasn't on anything, there was nothing on TV after 12:30 or so. It was just static. There was no reason to be up in the middle of the night. But now, kids have their cell phones in their bedrooms, and they're typically talking to their friends at 2 in the morning. So, you look at lifestyle. Is there anything we can do to help the kid there? And then, if you're following practice parameters, typically your next step is going to be talk therapy. And with talk therapy, most of the interventions for children are going to focus on something called CBT, cognitive behavioral therapy. As the name implies, there's sort of two big parts to CBT. There's the cognitive part and the behavioral part. So cognitive, what are the thoughts, the underlying thoughts, the ideas behind this issue, whether it's depression or anxiety, kind of what's going through your head. We all have, this, stream of consciousness running through us, and, we're always, there's a little bit of self-doubt, and it pops up for a second, and most of us are able to let it go away. But some people kind of latch on to those thoughts, and they just kind of keep focusing on ruminating and roll with it, and that becomes, kind of their defining outlook. So, you try to get kids to examine what they're thinking about, and then, what's the evidence for and against? How rational is this thought? Okay, you're worried about failing at school, but, it looks like you're a straight-A student. How realistic is this worry, this anxiety? And secondly, with cognitive behavioral approach, you're going to look at behavioral strategies to manage anxiety, and there are a lot of different approaches you can take with that. A lot of times, try to get kids to start with just kind of relaxation exercises, like breathing exercises, because when you're anxious, you stop using your diaphragm to breathe. You start using your intercostal muscles in your chest. So you're taking these rapid, shallow breaths, which that actually causes carbon dioxide to build up in the bloodstream. You're not getting enough oxygen in. And if you want to induce panic attacks in people, you just keep raising carbon dioxide levels. So deep breathing, even though some people might roll their eyes and say, that's what you're telling me to do. You don't have anything better than that. It actually can be a good place to start and a good place to work. We'll also use mindfulness exercises. You can do meditation or other relaxation approaches, progressive muscle relaxation or imagery exercises. There's a lot of different options out there, and so you try to kind of throw a few out to people, see kind of what works for them, and take it from there. When it comes down to medication, the approach tends to be with anxiety that you're going to look at antidepressant medications. Now, outside of obsessive compulsive disorder, no medications are FDA approved for children for anxiety. Now, what FDA approval means is that drug companies can market it to you. So we might be in a better world if nothing was FDA approved. We wouldn't have direct-to-consumer marketing, but it doesn't mean that there's not any research out there. We actually do have fairly good, controlled trials looking at these medications in kids. Obsessive compulsive disorder, like I said, it does have some indications under 18. So a lot of times people will start with the medications that do have approval for that, even if you're talking about generalized anxiety or separation or things like that. But there are several good choices. Now, a lot of people, when they're thinking about anxiety management, their mind might go to a class of medicines called Benzodiazepines. These are medicines like Xanax, Valium, Ativan, Klonopin. And those medications, they do work quick, and people really like them. But because of that, they really have a high abuse and dependency risk. So it's not the kind of thing we want to put kids on. There also have been a couple of controlled trials looking at those medications in kids, and they haven't been found to be efficacious. So the science really isn't there. They're addictive, they're habit forming, they cause cognitive dulling, so if you're in school, they're not going to make you clever. So even though those can knock out a panic attack, we don't use those typically in kids. And I have worked with a number of great families, and one of the parents might be prescribed benzodiazepine for panic attacks, and they come to the office for the first time, and they tell me that well, you know, little Timmy was having his panic attack, so I gave him half his Xanax, and it really worked well. I discourage you from doing that. Don't do that. Also with these medications, they work on the same receptors, the GABA receptors in the brain that alcohol works on. And just like you wouldn't give little Timmy a six-pack because he could become disinhibited and he could start acting out and become wild, you can see the same thing with benzodiazepines. So don't use those. If we're talking about medicines, usually we're talking about that antidepressant class of medication. So with mood disorders, really kind of the focus here is depression, but there are a couple of others that we might mention. Dysthymia is sort of this kind of low-level chronic depression. It's been going on years and years. People just more days than not, they're sad, they're down. But, in a week they might have one or two good days, but just kind of never really happy. So, kind of Eeyore, would be a dysthymic picture. Bipolar disorder or manic depression, there you're talking about, kind of two opposite poles. You've got the depressed, feeling down, feeling sad, but you've also got a mania, euphoria, top of the world, full of energy, starting a bunch of projects, mind's racing, don't need to sleep anymore. Bipolar disorder is extremely uncommon if you're talking about below the puberty age, so before 12 or so, you rarely would see someone with bipolar disorder. However, beginning in the 1990s, you saw a large increase in the diagnosis of bipolar disorder in young children. And doctors were kind of taking a different approach to making the diagnosis. It was really kind of looking at an ADHD presentation, hyperactivity, impulsivity, and also a little bit of emotional reactivity, mood lability, and calling that bipolar disorder. That really happened with a push from the pharmaceutical industry. There were a class of medicines called antipsychotics that are very helpful for treating bipolar disorder. And there was, again, a lot of pressure that, hey, maybe these could help out these kids. And if you look at some of the antipsychotic studies that have subscales for ADHD built into them, they actually can help out with those symptoms, but they come with so many side effects. I would not really recommend anyone to use them for that purpose. But all that's to say that you do have some people who kind of use a loose diagnosis of bipolar disorder, and you will see it sometimes applied to younger children. But a lot of times it doesn't really have that appearance of a classic manic presentation, when you're working in the emergency department and you meet someone who's manic, you're in the room less than 2 minutes, and you're like, this person's manic. Now, not all presentations are that clear cut, but it can definitely make an impression. With a classic bipolar presentation, usually what you're going to see is initial mood disturbance is going to be that of depression anyways. And usually you're going to see depression begin in the teenage years, and then you're not going to see a full-blown manic episode until your early 20s or so. So it always does put us a little bit on guard if we've got a convincing family history of bipolar disorder and we're seeing a kid who's depressed. Then I'm a little bit more concerned. But a lot of times if you're meeting a 7-year-old who's been told that they're bipolar disorder, a lot of times I'm questioning that diagnosis. Disruptive mood dysregulation disorder was something that was added to the DSM, that diagnostic manual I was telling you about, on the last revision back in 2013. And it was put in just because they were tired of people making a bipolar diagnosis in these little kids who are really emotionally reactive and that sort of thing. Because the diagnosis is relatively new, treatment approaches for it are still kind of being fleshed out. But what this is kids who are kind of chronically walking around angry, irritable, any little thing sets them off. So we've got kids who struggle with oppositionality. They're doing good, their mood's okay, until you tell them they can't do what they want to do, and then they might throw a little bit of a fit. But then you've got kids where just no matter what, they're kind of always, mad at the world. So, those are kind of things that are in that class of mood disorders beyond depression, but we're really going to kind of focus on major depression here. Of course, everyone has their ups and downs. Everyone's going to feel sad at times. You experience a significant loss, a breakup, death of a loved one. You're expected to have a grief and mourning. But when symptoms don't go away, when week after week after week, you're feeling like this, and especially if there's not a particular cause you can pinpoint, then we're worried about depression. So, we're talking about, feeling sad, feeling down, losing interest in activities you used to enjoy, feelings of guilt, hopelessness, crying episodes, tearfulness, appetite changes, more often loss of appetite, but sometimes you'll see an increase in appetite. Sleep disturbance, similarly to appetite, usually insomnia, but sometimes you'll see people who sleep too much. Low energy, hopelessness, worthlessness, and thoughts about suicide. So that's kind of the clinical picture we're talking about with major depression. So, depression, like most major mental illnesses, relatively uncommon before puberty. Now, puberty is also coming earlier and earlier and earlier as the decades go by. So we do kind of, those of us who have been in practice a longer time have to kind of keep thinking about that. Other differences with age. Young kids oftentimes they lack an emotional vocabulary. When you're really trying to get them to describe what's going on emotionally, they might not have the words to articulate it. So we do really depend on parents to kind of keep an eye out for changes as well too, because sometimes kids might not really be able to put their finger on it. With younger kids particularly, we see a lot more irritability as far as the observed mood state as opposed to kind of tearfulness, sadness. And then if you're just kind of comparing kids to teenagers, because kids have they're developing their reality testing. As you get older and older, right, you become kind of more certain about what's going on in the world. Imaginary friends, perfectly normal, in preschool, but hopefully as you get on into elementary school, the imaginary friends have served their purpose and they've gone away. Kids, because again their reality testing isn't going to be quite as good as teenagers, they are more likely to report hallucinations, voice telling them they're worthless, that sort of thing. Again, treatment strategies are going to be very similar to what you would do with anxiety, lifestyle, pretty much the same thoughts and approaches there. Talk therapies, most of the research does focus on CBT with depression, but interpersonal therapy is also evidence-based approach people will sometimes use. And medications, again, it's going to focus on the antidepressants. And if people have particular questions about that, I'm more than happy to answer them, but I wasn't really sure it would have large appeal to the crowd, so I'll just save that for a Q&A if you want to go into more detail there. Okay. All right. So next we'll talk about suicide, and we're going to talk about kind of overall impact, and then we'll also talk a little bit about some things that people question as far as could this be related, social media use, cyberbullying, that sort of thing. So we'll So, you know, there are some things that we really can't change that put people at increased risk for suicide. So, you know, if you've got a family history, if your parent has an untreated mental illness, males are more likely to have completed suicides than females, although you do see higher suicide attempts in females. Kids who are adopted, kids who identify as LGBTQ, and kids who have experienced abuse or placement outside of the home are all more likely. So we can't really change any of that stuff, but you know, if we know that a kid has some of those factors in their background, obviously we're going to be a little bit more cautious, try to keep a closer eye on them. Now, you know, if you know, there's things that we can change, obviously we want to address them. So mental illness. You got major depression, it increases your risk of suicide. So we can treat that. You know, substance use makes kids disinhibited, impulsive, you know, more likely to act out. So if we can get kids away from drugs and alcohol, obviously protected. Agitation, that's kind of that chronic irritability, that anger that you know, might not necessarily be part of depression. It could or could not. There are other issues that could contribute to irritability. But you know, there are things we can do to reduce that as well too. And then you know, life stressors, you know, kind of going through that breakup or having that you know, loss of a loved one, or you know, sports injury, you can't be on the team, academic change, you know, you were excelling and you faced a failure. You know, those immediate stressors can also put kids at risk, and we can obviously do a lot to support them during those challenging times. Then in the community, kids are more susceptible to what's described as the contagion effect. So you hear about a suicide, and then there can be a cluster of suicides around it. You see that a lot less in adults, but kids really are susceptible to it. So the media really tries to take steps to remove any glamour from a suicide. You know, the CDC has recommendations to media outlets about how they should approach coverage of suicides. And but any time that there's been you know, death of a celebrity, particularly ones that kids could be attached to, you know, you're going to worry and be on the lookout for increased suicidal behavior in the school. You know, if you're experiencing conflict in the home, kids who are taken out of the home, so that could be a placement in foster care, or placement in juvenile justice, or residential treatment. When kids are experiencing academic difficulties, or when they've you know, kind of been cut out from their peer group, if there's some ostracism going on there, those could all be risk factors. So again, many of them we could help correct, not all, but many we can help correct. Yeah, so as far as bullying is concerned, any child who is has any relation to bullying is at risk for increased suicide attempt. So kids who bully and kids who are bullied, both are at increased risk. The kids who are at the most risk are the kids who are doing both, that they're bullying other kids themselves and they're also being bullied. So yeah, the real message there is that yes, it's important to focus on the victim of bullying. You know, we want to support that kid, but the kid who was picking on him is actually at higher risk for hurting themselves. So, you know, we want to try to be supportive of them, see what's going on in their life, do what we can to help that kid out. You know, we can't just you know, brush them aside, because there's a reason that they're acting the way they're acting. You know, it's not that they're just a bad kid. You know, I'm not convinced that there's any kids out there that are just born bad and we should write them off. You know, there's a reason that this kid's angry. It doesn't excuse their behavior, but we need to do what we can to support them. So, you know, Girls experience more bullying than boys. You can see 23% of girls versus 15% of boys are experiencing bullying on a campus. And then cyberbullying, you got about the same numbers, 21% for girls, a little bit less for guys. They're not quite as socially engaged online as girls are, so about 8% of guys. And I probably should try to define these terms a little bit better. So with bullying, what we're talking about there from like a research perspective is that there's a power differential imbalance. So one kid is more powerful than another kid. That could be social capital, or it could be physical size and intimidation. And then there's ongoing repeated pattern of harassment. So two friends, like this is pretty common in my office. Got a kid come in saying, "Oh, I'm being bullied by so and so," and they were best friends, and then they had an argument, and that's not really bullying from a medical perspective. At least that's an argument between friends, because there's not that power differential, there's not that ongoing history. So it's chronic, and there's a power differential. Cyberbullying, with that's obviously you're being bullied through electronic communication. It could be Snapchat, it could be direct messaging, whatever you want to use. And pretty much every kid who is cyberbullied is also being bullied. So this is just kind of gravy on top of your basic bullying approach. And it removes safe harbor that kids used to have. So it used to be you could go home, and at least for most kids that could be a sanctuary or reprieve from bullying. This allows the bullying to follow you home, and allows it to be 24/7. If you're posting something on social media about an individual, they can go back at any time and look at that and see that. So it kind of keeps people ruminating about it. So that's one reason why, or two reasons why cyberbullying might be a little bit worse than just traditional bullying. So, some people have posited, is increasing internet use, contributing to increasing suicide rates, there's not a definitive answer with that yet, but there are a couple of points that raise concern. Pew Research, they do polls, every year or two about teenagers' habits and that sort of thing, and they look at electronics use and media use. And the latest Pew Research polls, if you're talking about teenagers, it's 95% of them have a smartphone, and 45% describe themselves as constantly online. So I was involved with a study probably about 8 years ago or so that was looking at the Youth Risk Behavior Survey, and it's got some questions with suicidality and electronics use and comparing those numbers. And with that, we saw that greater than 5 hours of internet use was associated with increased thoughts about suicide. So we've known for a while that there does seem to be a relationship here. And smartphones were introduced in 2007. It's really been kind of the past 5 or 6 years that they've been kind of ubiquitous to all teenagers. We've really gone through a real big shift in how people are interacting essentially, and it might be having some effect. So, some people question internet addiction. That's not a recognized DSM term, but they are investigating some, it potentially is a diagnosis as, kind of a problematic internet use disorder. But there do seem to be some kids that have trouble limiting how they function online, and you tend to see in studies that depression is worse in kids who who are constantly online without really purpose, kids who are just sort of surfing social media, kind of following one minute to the next without purpose, you see more depression in those kids. If you got kids who are accessing social media for a purpose, to communicate with friends, to make plans, that seems to be protective. You know, if it's kind of bolstering kind of real-world connections, it's a good thing. If it's just sort of mindlessly zoning out and seeing how everyone else has it better than you, it seems to be a bad thing. On the internet, you also do have normalization sites that kind of promote non-suicidal self-injury or thoughts about suicide. Anorexia's got a strong online community promoting those kind of those habits. So you do meet some kids who are kind of just really going to the wrong corners of the internet as far as having an influence on their mood. And then the contagion effect, which we discussed with general media, you know, that if you talk about suicide a bunch, you're going to see more suicides. You see that play out online as well too, particularly in anonymous forums. It seems to put kids at higher risk. So, like, say you're on Reddit or something, and you know, there's like a suicide watch subreddit there, and you're a member of that, and you know, someone kills themselves in that. That really seems to put kids at risk for further suicides. When it's suicide of someone connected to known social media accounts, someone that they've really got you know, a real world connection to, it doesn't seem to carry that same risk. It might allow the community to kind of come together and mourn a little bit online better than in an anonymous forum. Anonymous forums, you also see more trolling. So again, if you go to like you know, Suicide Watch on Reddit, you know, they you know, some of the pinned posts are, you know, warning about this troll do. If you know, you post that you're feeling suicidal, they're going to encourage you to commit suicide. And then, of course, you can have indirect triggers, stressors, cyberbullying. Fortunately, you know, suicide is relatively uncommon in young kids before puberty. We don't see a lot of it. But those kids who do commit suicide and are below, typically it would be kind of the age of 10 in a lot of the research, what you see is that it tends to be an impulsive act. So they really didn't think about the consequences, what they were doing, but they had access to a lethal means, and you know, they you know, weren't able to reverse that. So you see with this cohort, you see kids with ADHD, kids with high levels of family conflict, so they might not have that support at home, that close observation at home. These all tend to happen at home. You know, male, we said that was a risk factor. African Americans actually have a much lower risk factor than Caucasians for overall suicide rates. So, you know, this is a little bit of a standout issue that you know, you do see it more commonly in African American kids when you're talking about these real young suicides. And almost all of these are done through hanging. It tends to be the means. This is probably a little bit too small for anyone to see, but this is a Youth Risk Behavior Survey. Most recent findings, I think, were from 2015. It's a government data pool. They survey middle schools, high schools, ask kids about anything risky they're doing, you know, sex, drugs, driving without seatbelts, smoking, but depression symptoms and you know, thoughts about suicide are included. And you know, we've been seeing increasing rates with this. So this is kind of risk for suicide. But you know, with 9th to 12th graders, you got nationally about 17% consider suicide. 14% have made a plan. 8% have attempted. 3% the attempt was serious enough to warrant medical attention. The Georgia cohort with all of this is really drawn from the Atlanta metro area, so you could say it might not exactly be representational of the state as a whole, but Georgia rates are higher than the national rate when it comes to that most severe category. Those who sought medical attention was reported at 4.6%. And this is male up top, female death rates with suicide from 1975 to 2015, and teenagers, 15 to 19-year-olds. So you see, in the 90s, there was a real peak in suicide, and we had this nice trend, this nice drop, from the mid-90s into the early 2000s, and then starting about 2005 or so, we've seen that go back up. No one can say exactly why. We've come out of the recession. So there's not the economic stress. Social media, electronics use definitely has changed, which could impact sleep, bullying, those sort of things during that time. We also had the FDA put out a black box warning for antidepressants in 2004, which really changed primary care doctors, pediatricians, family practice, how they prescribe medications. So a lot of them stopped prescribing antidepressants to kids, and some people theorize that that could be part of the change too. But there's nothing's hard and fast about why we're seeing that, but we know that the risk has been going up. This is leading causes of death by age group 2016, most recent data from the CDC. We get 5 to 9-year-olds, 10 to 14-year-olds, 15 to 24-year-olds. Blue is accidental, so kids fortunately are healthy. Unfortunately, accidents are what tend to kill kids, but you can see the number 2 cause of death in teenagers and young adults. It's suicide. So this is something that is a public health crisis. In Georgia, these are completed suicides, and we got from 2012 to 2017. The blue is your teenagers, 15 to 17-year-olds. The red is 14-year-olds. As far as the means of death, 45% of these kids are firearms, and then 40% are hanging, 15% overdose. So, securing firearms in a household or removing firearms in a household, if you're worried about a child, is a very smart step to take. They've also found that if you're going to have firearms in the home, if you keep both the ammunition and the firearms locked separately, that also lowers risk for families who might not want to completely remove the weapons. All right, so seeking help, where to go? First, we talked about with the symptoms of depression and anxiety. When you're thinking about diagnostic statistical manual, the last thing is is it causing clinical impairment? Is it impairing the kid's function? So when we're seeing kids falling behind in school, they're having school refusal. You're seeing more behavioral disturbance in the classroom, temper tantrums. That might be warning signs that a kid's distressed, and you might want to look at the issue a little bit closer. And adolescence, similarly, change of performance, anger outburst, but substance use, withdrawing from activities that he used to participate in, used to enjoy, self-harm or making statements of self-harm. Unfortunately, a lot of times now, they're using social media to communicate these thoughts to their friends first off, and then the friends might bring it to the attention of an adult at school or home. So, those are kind of the things we'd be on the lookout for them. So, it can be tough sometimes to ask people if they're having thoughts about suicide. It's sort of my job, so I do it many times a day, every day, so I'll just say, hey, think about killing yourself. You know, again, I know it's not a conversation topic that comes up for everyone. So you can think about kind of going in a chain. You know, do you feel unhappy or helpless? Yes. Okay. Desperate, unable to face the day. Does life feel like a burden? Does life not feel worth living? Do you feel like committing suicide? So there's questions you can ask to lead up to it, and you might need to kind of probe a little bit further, depending on some of those earlier answers. But you know, if you don't feel like just kind of cutting down here to the bottom, you might sort of start at the top and work down. Okay. Go on. So, you know, things we can do to be supportive. We can help kids feel connected to their community. After-school programs are shown to be helpful for depression. Getting families involved at the schools so we can get to know them better, see if there's any additional support services we might need to offer them. Working on problem-solving skills with kids. There's been some controlled trials looking at schools and just interventions teaching kids how to manage conflicts and you know, distress, and it does seem to reduce suicidal ideation. Obviously, if we're identifying bullying, we want to work to correct that. You know, kind of moving the culture away from bullying as a whole. There's also there's a nice study out of Europe about 5 or so years ago that was looking at, you know, should we teach kids directly about depression, or parents, or teachers, or gatekeeper, mental health professional in the community. And the most effective strategy tended to be teaching kids themselves about, hey, this is what depression looks like. You know, if you're experiencing this, if you're having thoughts about suicide, or a friend is, you know, here's where you'd want to refer them to. So really educating kids has been shown to be helpful as well. All right, so in the home, if you got firearms, I would recommend removing them. If you don't want to remove them, keep them locked separately, like we said. Keep kids away from drugs and alcohol. They don't improve decision making. They make kids more impulsive. Many substances themselves are depressant, so it's just going to worsen any affective disorder. If there's conflict in the home, you know, working to reduce that, and you know, getting the kid engaged with the community. You know, strong religious and spiritual beliefs tend to be protective. So if a kid is involved with a church, that's something that could actually work in their favor when we're thinking about suicide. Okay. So finally, community resources. Just a couple of numbers here. Georgia Crisis Access Line. This, you know, if you're having thoughts about suicide, they can, you know, talk to people about that, but they can also kind of get you plugged in with someone in the community. And really, it's a pain in the neck trying to figure out where to go and, you know, all that. So they can be a benefit. You know, if you had a student here who was, you know, thinking about suicide and you weren't quite sure what to do with them, sending them to the emergency department, that's always one option. But another option would be called the Georgia Crisis and Access Line. And then for people who might be experiencing thoughts about suicide, of course, you got the National Suicide Prevention Lifeline. And there's also crisis text line, where kids, if they don't want to talk directly to someone, they can text and get support that way. In the community, you know, you got NAMI, National Alliance of Mental Illness. You know, can offer support to families. Georgia Department of Behavioral Health and Developmental Disabilities, that's going to be more for kids who have significant impairment, you know, autism, intellectual disabilities, major mental illness. Serenity, you know, is our community mental health service provider, and they work with some kids, but again, typically those kids who are severely impaired, you know, early onset psychosis, that kind of thing. MCG, Augusta University, Department of Psychiatry and Health Behavior. You know, we've got a number of child and adolescent psychiatrists. We've also got psychologists who work with kids. Hopefully you guys aren't having kids go with DJJ, but they do have a list of community services outside of just being locked up. Transitional Family Services and Stillwaters, these are like core service providers in the community. They're going to primarily work with families that have Medicaid coverage, so unfortunately private insurance doesn't really work with them. Lighthouse Care Center of Augusta and Aurora Pavilion in Aiken are both UHS operated facilities. We do have a working relationship with Lighthouse, so we provide the doctors there, but they do all the other staffing stuff. And they've got an acute unit, so kids who are at immediate risk of hurting themselves can go there. We've also got what's called a partial hospitalization, both them and Aurora, where a kid who at least is safe at home overnight can go to the hospital for 2 weeks to receive regular counseling services and medication management. And then they've also got residential care, which is like when a kid's kind of in the hospital for months and months and months at a time. It's really sort of the last resort. There's also a number of other private psychologists in the community. I really like the folks at Families Forward. I really like Kevin Turner. There's many good choices, and again, I'd be happy to kind of direct you to some of those for psychological services. Psychiatric services outside of us, there's Dr. Babato, there's Dr. Muslim at Serenity, but they're really, the majority of the psychiatrists are at AU. Just a little secret, you do have one of our faculty, her children go here. I was trying to pressure her to give the talk, but she felt like that she wanted her children to be able to act the fool and not have everyone saying their mom's a child psychiatrist. Why are you acting like that? But if you dig around, there is someone right here who you can talk to. But also, if you ever have concerns about a kid, just reach out to me. I'll try to help you kind of navigate this, because it really can be a challenge when you're saying, where's my insurance going to work and all that. It can really be a pain. Questions?
I was going to ask a little bit more about media guidelines and kind of what you see as a little more safe. I mean, I know people as young as 10 get iPhones, and are there guidelines out there now, or what are the rules? I have a 4-year-old, so she's not going to get a phone anytime soon. She wants mine.
Yeah, the American Academy of Pediatrics has historically done the age use guidelines, but their last revision, they made it a little bit more kind of flexible, so it didn't offer parents as much kind of strict guidance about when to think about all this. I'd say keeping media out of the bedroom is a smart idea. It just leads to so many sleep disturbance. I think sleep is kind of behind a lot of other problems. So I really try to encourage families to keep the smartphones out of the bedroom at a minimum. Most social media, doesn't want people under the age of 13 accessing their sites because the government says that they're not allowed to track them for direct advertising. So they just said, okay, well, it's easier if we just don't have them. So I always try to get parents to think about, well, you want to project to your kids that we follow the rules, and the rules say that we're not supposed to sign up before 13. So I really try to kind of encourage parents to try to keep kids off social media before 13. And then, it kind of comes down to, the maturity of the child. If you give a kid a smartphone, they've got access to everything in the world. And, do you trust them to, have the maturity not to access that when they're out of your sight, So usually I try to get parents to introduce electronics and internet access with direct observation okay, we got to share all the passwords. I'm going to be following up, checking up behind you to see what you're up to. You know, as you mature, then you get more autonomy. It's a lot easier to kind of grant rights than to take them away after there's been trouble. The technology providers are becoming more aware of this issue, and the new iPhone iOS update does have pretty good parental controls on it. So, you know, you might also kind of, you know, the Amazon Fire devices also have pretty good parental controls. So, you know, you might also look at which devices are easier for you to, you know, manage. You know, that being said, kids are going to work around you. You know, I've known plenty of teenagers who had their, you know, electronics stripped away, but their friend's got a 3-year-old phone and hands it to them, and then wherever there's Wi-Fi, they're back online. So, yeah, you know, you do what you can.
Hopefully we cover some of that in our next session, the technology piece too. I'm sure we'll touch on that.
Hey, I have 3 questions. You had talked about interpersonal therapy, I think under anxiety. I just wanted you to explain that to me. And the genetic disposition, I think, in cases of anxiety, what is the research for that in terms, I know you had shown that if a family member had committed suicide, then they're in higher risk. Could you talk about that in terms of anxiety? And with teens, I have 2 teenagers, it seems like, you know, twice a week we're having anxiety caused by anything, just circumstances. Is the main determinant that over the course of time, if that high level of anxiety remains, is that what you're looking for as a parent in determining what's life and what's a diagnosis?
Yeah, so, you know, we'll kind of work backwards on that. You know, what's life and what's a diagnosis? It can be difficult because, you know, teenagers can be very emotional or reactive, and sometimes the current mood that they're in can really color, you know, how they kind of look at how they've been doing in the long run. So, you know, have kids I'm working with who come in the hospital and tell me, oh, you know, I've been depressed for years and years, and it was just this breakup with my girlfriend that kind of tipped me over the edge. And, you know, then, you talk to the family and they say, well, they were looking good before the breakup, and then, you know, continue to follow them as an outpatient, and, you know, with medication, usually you're looking at like, you know, a month before the medication is really effective. So, you know, you see them a couple of weeks later, they've sort of bounced back because they're talking to this other girl, you know. So, you know, sometimes it can be tough, you know, with kids to really kind of suss that out. And you're more in the parent role and kind of observing, and even there, you know, you're sort of seeing, well, you know, keeps coming up and up and up, and we've got these good stretches in between. And, you know, with depression, you are looking for more of kind of observed, you know, chronic change. But anxiety can be a little bit more punctual, you know, things like separation anxiety, social phobia, that it's really going to kind of be situation specific. So sometimes, you know, anxiety might have that, you know, spiked pattern that you described. But, you know, if you're seeing that pattern and it's causing significant destruction, they're not able to function and do what they want to do. That's when I'd say, well, maybe we should think about doing something about it. Let's see. Then you asked about family history contribution, and the other question was interpersonal therapy. Yeah. So. Yeah, anxiety does have a familial pattern similar to many mental health issues. It's not going to be the sole determinant by any stretch, but, you know, about 30% or so of it, you know, you could look at it as kind of, you know, from a family contributing, but, you know, it still leaves a lot of room for, you know, kind of how the individual, you know, approaches and manages their stress. Interpersonal therapy, as the name sort of implies, is really focusing more on interpersonal relationships and seeing how we can strengthen those to, you know, support a kid. So relationships with the parents, but also, you know, friendships, and, you know, really drawing on that as a source of support would be kind of the thumbnail